Hi everyone, good evening and welcome to this ophthalmology session of this FMG Accelerate. So please let me know if I am audible and visible. Please let me know if I am audible and visible. And then we can go ahead. Please let me know if I am audible and visible. Okay, thank you. So let's start with this session of FMG Accelerate. So in this, what we'll be doing is essentially we will be looking at the questions which have come in the FMG exam in the past few years, and we will try to revise those topics because see, as we have seen in most exams and also in our recent NEET PG, it's even if the question is not repeated, it is very likely that the topic is going to be repeated. So let me start with the questions. Let's look at the first question. So a 3-month-old baby presents with mucus exuding from the eye on pressing the lacrimal sac. What is the treatment that should be given? So can you tell me what is the answer? So a 3-month-old baby presents with mucus exuding from the eye on pressing the lacrimal sac, and what is the treatment that should be given? So see, there is the options given to us are lacrimal sac massage, syringing, probing and DCR. DCR, I hope you know, stands for dacryocystorhinostomy. Dacryocystorhinostomy. So tell me which is the answer, which of the options are we going to choose here? Correct. The answer is lacrimal sac massage. So first of all, what is the diagnosis? They are saying that there is a baby and the basic complaint is watering, and when you press here on the lacrimal sac, then you get mucus coming back into the eye. So that essentially means that what is the test that is positive? This test is called as regurgitation test. So regurgitation test is positive. So what is the diagnosis here? The diagnosis here is congenital dacryocystitis. Congenital dacryocystitis, which is also called as the congenital NLD block. Congenital NLD block. Congenital nasolacrimal duct block. That is our diagnosis, right? So now this is what these children essentially look like. So see, look at this. This is what these children will look like. They will have the mother will complain of watering. There will be mucus like this here, and on pressing the lacrimal sac, we will get to see mucus exuding out. So that gives us a diagnosis of congenital NLD block. I'll come back to the question, but before that, tell me the answer to another very common question. What is the site of block? What is the site of block in case of congenital dacryocystitis? Tell me, what is the site of block? Who will tell me? What is the site of block? Very important question. Very commonly asked also. What is the site of block? Okay, I'll tell you, the site of the block is the valve of Hassner. Please memorize this. This is very important and commonly asked MCQ. So in congenital NLD block, if we are asked what is the site of block, it is the lower end of the NLD, that is the valve of Hassner, where this NLD joins with the inferior meatus of the nose. So at that point, there is a valve which is called as valve of Hassner, and that is the site of block in congenital dacryocystitis. Again, as I told you, important MCQ. Right? What is the complaint of these children? They are brought with complaint of watering and discharge, and this is what they look like. And what is the treatment? Essentially, the treatment is initially conservative, and that is lacrimal sac massage. You ask the mother to massage the area of the sac. But see, there is a trick in this question, and that is the age of this baby. So look at the age of the baby. If the age of the baby is less than 1 year, then we are going to mark lacrimal sac massage as our answer. But suppose in this same question, the age of the baby is more than 1 year, then we are going to mark what? Then what is the answer? if the age of the baby, if the question is the same, but they say that the age of the baby is more than 1 year and the mother has been doing lacrimal sac massage for a year, but then the child has not improved, then which answer will you mark? Very, very, very commonly asked question. So if the age of the child is more than 1 year and the question says that the mother has been doing the sac massage for some time and still the kid has not improved, then the answer is going to be probing, right? So then the answer is going to be probing. And if the age of the child is more than 3 years and the child and multiple episodes of probing have been done and it has failed, then the answer is surgery. And what is the name of the surgery? The name of the surgery is this, that is dacryocystorhinostomy or DCR surgery. Okay, so I'll just repeat the MCQs that you had to memorize from here. Number 1, what is the site of obstruction in congenital NLD block? The answer is the valve of Hassner. What is the presenting complaint? The presenting complaint is watering and discharge. What is the test, clinical test that is positive? The clinical test that is positive is regurgitation test. What is the management? The first line of management is lacrimal sac massage, and this is to be done till the child is about 1 year of age. If the child is more than 1 year of age and the massage has not worked, then we can go for probing. And if the child is more than 3 years of age and still symptomatic and multiple episodes of probing have been done for the child, then surgical management can be considered. And what is the name of the surgery? The name of the surgery is DCR, dacryocystorhinostomy. Okay, now one more MCQ that is asked from here is, in DCR surgery, it is an anastomosis between the sac and the nose, that is DCR surgery. So in DCR surgery, the anastomosis is between the sac and which meatus of the nose? In DCR surgery, the anastomosis is between the sac and which meatus of the nose? See, the NLD is opening into inferior meatus, but in DCR surgery, the anastomosis of the sac is with the middle meatus of the nose. Please remember this also. This is also an important MCQ. So in DCR surgery, the anastomosis of the lacrimal sac is with the middle meatus of the nose. Okay, so in this question, if age is less than 1 year, mark sac massage. If the age is more than 1 year, then you mark probing. If the age is more than 3 years and the question says that multiple episodes of probing have not worked, then the answer is dacryocystorhinostomy. And in DCR surgery, the anastomosis of the sac is with the middle meatus of the nose. All these are actually MCQs. Every one of them you have to learn and memorize. Okay, so shall we go to the next question? Have a look at this. Again, a very, very, very commonly asked question. Which lesion of the visual pathway produces macular sparing field defect? Which lesion of the visual pathway produces macular sparing field defect? So which is the answer? Optic chiasma, occipital lobe, optic nerve, optic tract. So which one are you going to mark? Correct. The answer is occipital lobe. So macular sparing field defect, this is seen in lesion of occipital lobe. So let us see what are the other. For optic chiasma, what is the defect? For optic chiasma, the defect is a bitemporal hemianopia. So for optic chiasma, it is bitemporal hemianopia. And for optic tract, please remember, it is a homonymous hemianopia. So bitemporal hemianopia for optic chiasma and homonymous hemianopia, which is for the optic tract. Okay, so macular sparing field defect for occipital lobe, bitemporal hemianopia for chiasma and homonymous hemianopia for optic tract. So I just want you to see a couple of images also. So this, instead of asking the same thing in a text form, the same thing can also be asked in case of this kind of an image. So when you get this kind of an image, so see in this represents the image, the field of the right eye, and this is the left eye. So this is the nasal part of the field, this is temporal, this is nasal, this is temporal. So see here, the temporal fields of both the eyes are lost, and so this is bitemporal hemianopia. So if you get this image in the exam, you should be able to identify it as bitemporal hemianopia. And what did I just tell you? That if there is bitemporal hemianopia, the site of the lesion is the optic chiasma. Optic chiasma. So see here in this image, the temporal field of both the eyes, they have been blacked out. Okay, now look at this. Suppose you get something like this. Here, see, this is nasal, this is temporal, this is nasal, this is temporal. So the nasal field of one eye and the temporal field of the other eye is blacked out here. So see, the nasal field of one eye and the temporal field of the other eye is blacked out. So this is called as homonymous hemianopia. Okay, homonymous hemianopia. So here, if you get this image in the exam, then the answer has to be optic tract. So the site of the lesion is the optic tract. And the one that you got in the question is this. This is macular sparing. Here also see, you get something like a homonymous hemianopia, but there is an area at the center which is clear. So that is called as macular sparing. So it's like a homonymous hemianopia only. Look at this image, it's very similar, but the central area is clear. So this homonymous hemianopia with macular sparing, here the site of the lesion is the occipital infarct. Sorry, this is because of occipital lobe lesion or occipital infarct. Okay, so this is something which you have to, all these you have to learn, and also you have to look at, be able to identify these images also, right? So just to quickly go over this once more, see, for optic chiasma, it is bitemporal hemianopia, that is this. For optic tract, it is homonymous hemianopia, that is this. And for occipital lobe lesion, it is macular sparing. Now see, the same question has been asked again. Have a look at this. There is a tumor in the anterior pituitary which causes pressure over the optic chiasma, and this presents as what? So what are the options? The options are C, homonymous hemianopia, bitemporal hemianopia, monocular vision loss, heteronymous hemianopia with central sparing. Right? So what is the answer that we have to give here? A tumor in the anterior pituitary is causing a pressure over the chiasma and it is presenting as this. So tell me, what is it that we have to choose over here? We just read this. This is the, in like a couple of years, the same question has been repeated twice. So what is our answer? Obviously the answer is, so this is your optic chiasma, right? This is the optic chiasma. So the answer obviously is bitemporal hemianopia, which we just saw. If there is a lesion which compresses the optic chiasma, you're going to get a bitemporal hemianopia. But see here, I want you to learn up another MCQ. See, it says a tumor in the anterior pituitary causes pressure over the chiasma, right? So now what are the pituitary tumors that compress the optic chiasma and can present as bitemporal hemianopia? So what are the tumors, do you know? Will you be able to tell me what are the tumors of the pituitary, or what are the tumors not just of the pituitary, what are the different tumors which can compress the chiasma? The pituitary, it can be pituitary adenoma, and can you tell me the name of another important tumor that you have to memorize? Pituitary adenoma is one and the other is, okay, I'll tell you, craniopharyngioma. It is craniopharyngioma. So pituitary adenoma and craniopharyngioma, both these tumors, they have the potential to compress the optic chiasma and they can cause bitemporal hemianopia. So this we have to remember, right? So these questions on the visual pathway, they have been asked again and again, multiple number of times they have been asked, and they are likely to be asked again. So we have to know them well. Okay, chalo, let's go to the next question. A patient presents with miosis, anhydrosis, and drooping of the upper eyelid, slight drooping of the upper eyelid. So what do we mean by slight drooping of the upper eyelid? It basically means that there is a mild ptosis. So miosis, anhydrosis, and a mild ptosis. And they have given us this picture. So what is the answer here? Third nerve palsy, Horner, sixth nerve palsy, orbital cellulitis. So what is the answer here? Will you be able to tell me? What is the answer? Correct. Very good. The answer is Horner's syndrome. Horner syndrome. Now, what is the other name of Horner syndrome? The other name for Horner syndrome is oculosympathetic palsy. So, please remember this name also. So, instead of Horner syndrome, they can also give us this name, oculosympathetic palsy. So, in oculosympathetic palsy, what are the different things that are affected? What is affected is, number one, the dilator pupillae muscle is affected. So please remember this, because the dilator pupillae muscle is affected, you tend to have miosis, that is constricted pupil. So because the dilator pupillae is affected, you have miosis. Second, because the Mueller's muscle is affected, you tend to have a mild ptosis. So because the Mueller's muscle is affected, we are going to have a mild ptosis. And third, because the sweat gland is affected, we are going to have anhydrosis. So because the sweat gland is affected, we are going to have anhydrosis. So in oculosympathetic palsy or Horner syndrome, these are the things we have to remember. So oculosympathetic palsy or Horner syndrome, the dilator pupillae muscle is affected, so we have miosis. Mueller's muscle is affected, so you will have a mild ptosis, and the sweat gland is affected, so you have anhydrosis. So here it was easy, but suppose they give us only this image, then also we should be able to identify this. So look at this, this is the right eye and left eye. See, in an image, you will be able to make out two things. One is, see, this eyelid is slightly low, so there is a mild drooping or a mild ptosis. So here you can make out the mild ptosis, and if you look at the pupil, you will see that the pupil is smaller as compared to the other eye. So in an image, these two things are visible. So there is a mild ptosis and there is miosis. Obviously anhydrosis you will not be able to make out in an image, but if they give you this image with the relevant history, then also you should be able to answer the question. Okay, so let's go to the next question now. Let's go to the next question. Again, a question that has been repeated many times. A 10-year-old boy complains of itching and watering in both eyes, and on eversion of upper lid, the following picture is seen. What is the diagnosis? Is it a bacterial conjunctivitis? Is it trachoma? Is it vernal keratoconjunctivitis? Or is it angular conjunctivitis? So what are we going to mark here? What is this? A 10-year-old boy complains of itching, watering, and on eversion of the upper eyelid. This is the picture that is seen. So what are we going to? Very good. So this is vernal keratoconjunctivitis. Vernal keratoconjunctivitis, which is also called as spring catarrh. This is also called as spring catarrh. And here this is commonly seen in boys between 5 to 15 years of age. It is a type of allergic conjunctivitis. What kind of conjunctivitis is it? It is a type of allergic conjunctivitis, and that is why, see, the complaint is itching and watering. And when you evert the upper lid, you see these flat topped elevations here. These kind of squarish flat topped elevations, they are called as the papillae. And this appearance has got a name. What is this appearance called? It is called as the cobblestone appearance. What is it called? It is called as the cobblestone appearance. This is very important. This image, it has come multiple number of times in different exams. And also, what is the appearance? The appearance is called as the cobblestone. Okay, so this is vernal keratoconjunctivitis. Now, will any of you be able to tell me vernal keratoconjunctivitis is what type of hypersensitivity reaction? Type 1, type 2, type 3, type 4? Again, a commonly asked MCQ. What type of hypersensitivity reaction is this? What type of hypersensitivity reaction? Type 1, type 2, type 3, type 4? Okay, let me tell you, it is a type 1 hypersensitivity reaction. Very important to remember. It's a type 1 hypersensitivity reaction. Right? It's a type 1 hypersensitivity reaction. So it is mediated by IgE, and the cells that are involved in the pathogenesis are the mast cells. These are also asked in exam. Type 1 hypersensitivity reaction, IgE and mast cells. And in very, very severe cases of VKC, what happens is these papillae, they rub onto the surface of the cornea, and you tend to get multiple corneal erosions, and if left untreated, it can proceed to form a large corneal ulcer. What is the name of this ulcer? Again, another important MCQ. What is the name of the corneal ulcer seen in VKC? Will anyone be able to tell me what is the name of the ulcer that is seen in VKC? Another important and commonly asked MCQ, the ulcer that is seen in VKC, this is called as your shield ulcer. What is it called? It is called as shield ulcer. Okay, so in cases of VKC where these papillae are very large and they tend to rub on the surface of the cornea and they cause corneal erosions, and if it is left untreated, you tend to get a large ulcer which is called as the shield ulcer. Okay, so this is a very, very, very commonly asked question in FMG exam, that is on vernal keratoconjunctivitis, also called as spring catarrh. Now, I'll show you another question which is also kind of similar, but the answer is different. So, see, a patient presents again with similar complaints, that is itching, foreign body sensations, and he has a history of contact lens usage. And what is the most probable diagnosis? So here, what are the options we have? Here the options are corneal abrasion, vernal keratoconjunctivitis, giant papillary conjunctivitis, and corneal ulcer. So tell me, which one will you choose here? Corneal abrasion, vernal keratoconjunctivitis, giant papillary conjunctivitis, corneal ulcer. So which is the option that we are going to choose here? So here also, if you see, the complaint is very similar. There is itching and foreign body sensation, and there is, but what is, and if you look at the image is also not very different. Here also you got these kind of squarish papillae, and here also what you are seeing are also, these are also papillae only. So these are also papillae. So these are also papillae, but these papillae, they are large. They are large papillae, unlike the papillae that you saw in VKC. In VKC also we will get papillae, but they are like slightly smaller. Here we are getting large papillae. So this is called as giant papillary conjunctivitis. And this is not VKC. Students make a mistake of looking at this image and thinking it's VKC. It's not VKC. See, in a question on VKC, I'll just go back to the previous question. They will always mention that it is a boy. That will always be mentioned. And the age of the boy will be between 5 to 15 years, and there will be, sometimes they mention that there is a recurrent complaint of itching and watering, but this boy will always be mentioned, and that is what kind of guides you to the clue that the answer is VKC. But in this question, see, what they have mentioned is contact lens usage, because this kind of giant papillary conjunctivitis, this is seen if you have something like prolonged use of contact lenses. It can happen if you have protruded sutures also. If you have protruding sutures after a surgery, or if you have these kind of contact lens, prolonged ill-fitting contact lenses, they tend to protruding sutures, ill-fitting contact lenses. These are important causes of this kind of allergic conjunctivitis, where you have papillae but they are large. So it's called as giant papillary conjunctivitis. Okay, so the image is very same, but the history is different, and that is what guides us to the answer. So this is again important to remember in the exam. Okay, another very, very simple question. What is the cause of acute hemorrhagic conjunctivitis? So the options given to us are coronavirus, adenovirus, enterovirus, herpes. Coronavirus, adenovirus, enterovirus, herpes. So tell me, what should we choose here? Coronavirus, adenovirus, enterovirus, and herpes. Actually, here there are two correct answers. Okay, so the causes of hemorrhagic conjunctivitis, they are remembered as ACE. ACE. A obviously stands for adenovirus. C stands for Coxsackie virus. Coxsackie virus. And E has two, that is enterovirus and ecovirus. So the causes of acute hemorrhagic conjunctivitis, they are remembered as this ACE, right? ACE, adenovirus, Coxsackie virus, enterovirus, ecovirus. So here adenovirus and enterovirus are both correct, but adenovirus tends to be far more common cause of hemorrhagic conjunctivitis. So this is what we will mark. We should mark adenovirus. Adenovirus is a more common cause of hemorrhagic conjunctivitis. So we will mark adenovirus as the answer, but actually enterovirus is also correct. Adenovirus, Coxsackie virus, enterovirus and ecovirus. These are the causes of acute hemorrhagic conjunctivitis. Okay, let's go to the next question. Which of the following is the gold standard for measuring intraocular pressure? Which of the following is the gold standard for measuring IOP? The options are Schiot's tonometer, tonopen, pulse air tonometer and Goldman applanation tonometer. Which of the following is the gold standard for measuring intraocular pressure? Schiot's, tonopen, pulse air tonometer, Goldman applanation tonometer. So who will tell me the answer? Which of the following is the gold standard? Schiot's, tonopen, pulse air tonometer, Goldman applanation tonometer. Correct. It is the Goldman applanation tonometer, which is the gold standard for measuring IOP. So this is a simple question, but I just want you to look at a few related images which have also been asked. So look at this image. This is the image of Goldman applanation tonometer. This is the Goldman applanation tonometer. This can come as a simple image based question. This is your Goldman applanation tonometer. And see, this is attached to your slit lamp. This is attached to the slit lamp. So this cannot be used without the slit lamp. And this is the biprism which touches the surface of the cornea. So see, this is how the IOP is measured. The patient is made to sit on the slit lamp. He keeps the chin on the chin rest. And see here, what you have to do is, please remember this. This has been asked this year in the NEET PG. That the tear film is stained with fluorescein dye and you put on the cobalt blue filter of the slit lamp. Please memorize this. That's why, see, the background light is blue. So you stain the tear film with fluorescein dye, you put on the cobalt blue filter of the slit lamp, you anesthetize the cornea and you make the cornea touch the surface, and you make the applanation biprism touch the surface of the cornea. Okay, and then only you will be able to record the intraocular pressure, and this is the examiner's view. So what does the examiner see? The examiner sees two semicircles like this. Two semicircles like this. So these two semicircles that the examiner sees, they are called as the applanation tonometry Myers. And you have to take the pressure when these two Myers are just like touching each other, just overlapping or just touching each other. That is when you have to take the IOP. Okay, so these three images I want you to remember. So have a look at this image. You can get this image. This is the Goldman applanation tonometer. This is the procedure of applanation tonometry, where the dye that is used is fluorescein dye. The filter of the slit lamp that is to be put on is the cobalt blue filter. And this is the examiner's view, where you get to see two semicircles which are called as applanation tonometry Myers. And you have to take the pressure when the two semicircles are just touching each other. Okay, all these are potential MCQs. Now, one more question I want you to know. Now see, this applanation tonometer cannot be used if you have an irregular cornea. That's if you have a very bad corneal scar or an opaque cornea. This Goldman applanation tonometer cannot be used. That is its drawback. So then we come to another important MCQ, which is the tonometer of choice for irregular cornea, and the answer is tonopen. So tonometer of choice for irregular or scarred cornea. The tonometer of choice for irregular or scarred cornea, that is your tonopen. So this also, please remember, this also can come as an MCQ, tonometer of choice for irregular or scarred cornea. So gold standard tonometer is Goldman applanation, but it cannot be used for irregular cornea. So for irregular cornea, you will use tonopen. Okay, so these are some very potential questions. Let's go to the next one, next MCQ. Have a look at this. Beta blockers should be avoided in all conditions except glaucoma, peripheral vascular disease, diabetes, COPD. So beta blockers should be avoided in all conditions except glaucoma, peripheral vascular disease, diabetes and COPD. So what is the answer? Obviously, because we are discussing ophthalmology, it's become very easy to answer this question. The answer is obviously glaucoma, because beta blockers are used in the treatment of glaucoma. Beta blockers are used in the treatment of glaucoma. So I will just take the opportunity of this question and I will quickly discuss the important points about the anti-glaucoma drugs. Okay, so under the anti-glaucoma drugs, the beta blockers, will you be able to tell me which is the beta blocker that is commonly used as anti-glaucoma medication? The most commonly used one is timolol. Timolol, this is used as 0.5% eye drops. 0.5% eye drops. Okay, now the next one. The next one is alpha receptor agonist. Alpha receptor agonist. Which is the important alpha receptor agonist which is used as anti-glaucoma? Will you be able to tell me the alpha receptor agonist which is used as anti-glaucoma? Again, important MCQ. Alpha receptor agonist which is used. Okay, I'll tell you, please memorize this. Brimonidine. Brimonidine eye drops. Brimonidine eye drops. Very, very, very important. Okay, then the third is carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. So which are the carbonic anhydrase inhibitors which are used? Now here, under the carbonic anhydrase inhibitors, please remember we have a systemic member. Which is the systemic member? The systemic member is acetazolamide, which is used as a in tablet form. Acetazolamide, which is used in tablet form. And we have topical members also. So which are the topical members? The topical members are dorzolamide and brinzolamide. See, this question has been asked in the next one. I'll just show you. Dorzolamide and brinzolamide, these are used as eye drops. Okay, so just have a look at this. The first class is beta blocker, that is timolol, which is used as 0.5% eye drops. Alpha receptor agonist, brimonidine eye drops. Carbonic anhydrase inhibitors, the systemic member is acetazolamide, which is used as a tablet, and the topical members are dorzolamide and brinzolamide, which are used as eye drops again. Now, just remember that these three classes, that is beta blockers, alpha receptor agonist and carbonic anhydrase inhibitors, what is the mechanism of action? They decrease the aqueous humor secretion. They decrease the aqueous humor secretion. That is, they suppress the production of aqueous humor. That is their mechanism of action. So these three classes of drugs, they decrease the aqueous humor production. Okay, now the other important classes of drugs. What are the other important classes of drugs? The other important classes of drugs are prostaglandin analogues. Prostaglandin analogues. So will you be able to tell me the names of prostaglandin analogues? Which are the prostaglandin analogues? Chalo, tell me, what are the prostaglandin analogues which are used as anti-glaucoma? This has come a couple of years back in NEET PG exam. So it can come in FMG also. Okay, I'll tell you the important names you have to remember is latanoprost, travoprost, and bimatoprost. Latanoprost, travoprost, and bimatoprost. Latanoprost, travoprost, and bimatoprost. Okay, these are prostaglandin analogues. Next group is which one of you was saying, that is myotics. Under the myotics we have pilocarpine. Under the myotics we have pilocarpine. And we have another newer class of drugs which are called as Rho kinase inhibitors. Rho kinase inhibitors. Okay, so prostaglandin analogues, myotics, Rho kinase inhibitors, what do these classes of drugs do? They increase the aqueous outflow. So they increase the aqueous outflow. So the previous three classes of drugs which I told you, they are decreasing the aqueous humor production, that is beta blockers, alpha receptor agonists, and carbonic anhydrase inhibitors. What are they doing? They are decreasing the production of aqueous humor. Whereas these classes of drugs, that is the prostaglandin analogues, the myotics, and the Rho kinase inhibitors, what they are doing is they are increasing the outflow of aqueous humor, and thereby they help to decrease the intraocular pressure. And the last class of drugs, which are essentially systemic drugs, they are called as your hyperosmotic drugs. So we have the hyperosmotic drugs, and the hyperosmotic drugs are mannitol and glycerol. They are mannitol and glycerol. And what do these classes of drugs do? See, the previous classes of drugs were all acting on the aqueous, but these classes of drugs, they dehydrate the vitreous. They dehydrate the vitreous and they decrease the intraocular pressure. So their site of action is not mainly the aqueous humor, it is the vitreous humor. So they dehydrate the vitreous and they help to decrease the intraocular pressure. So this much is very, very important. Do remember this much. So the first three classes, beta blockers, alpha receptor agonists, and carbonic anhydrase inhibitors, they decrease aqueous humor production. The next three classes, prostaglandin analogues, myotics, and Rho kinase inhibitors, they improve the outflow of aqueous humor. And the last category of drugs, that is the hyperosmotic drugs, they do not mainly act on the aqueous humor, they are acting on the vitreous humor. They reduce the IOP by dehydrating the vitreous. Right? Now look at this question. So we have learned all this. Now have a look at this. Abhi isko dekho. Which of the following carbonic anhydrase inhibitor is used in glaucoma? Now I want everybody to be able to answer this question. So timolol, latanoprost, mannitol, dorzolamide. So which one will you mark? Which one will you mark here? इसमें कौन सा mark करना है? Which one am I going to mark? Obviously, we are going to mark which one? Obviously, we are going to mark dorzolamide, right? So this is your carbonic anhydrase inhibitor. So see, this timolol is beta blocker. You should be able to answer all of this now. Latanoprost is a PG analog, prostaglandin analog. Mannitol is a hyperosmotic drug. And dorzolamide is your carbonic anhydrase inhibitor. This is your carbonic anhydrase inhibitor. Okay, so this is again, see, this is a repeat question. If you read the previous question, the topic has again been repeated. Right, so next question pe chalte hain. Let's go to the next one. Look at this. This question has come multiple times in FMG. It has come this year in the NEET PG exam also. A newborn child has presented to us with watering, photophobia, and blepharospasm. And on examination, this is the picture. What is the diagnosis? So the options are ophthalmus, congenital cataract, megalocornea, and congenital dacryocystitis. Ophthalmus, congenital cataract, megalocornea, congenital dacryocystitis. So which one are we going to mark here? Very, very obvious kind of answer, but tell me. इसमें कौन सा mark करेंगे? A newborn child presents with watering, photophobia, and blepharospasm, and on examination, this is the picture that's seen. What is your diagnosis? Okay, so the answer is ophthalmus, that is congenital glaucoma. So you can either have congenital glaucoma in the options, or you will have ophthalmus in the option. Okay? So it's a baby, and what is the triad? Please remember this triad of symptoms. The triad of symptoms is watering, that is lacrimation. We remember this as lacrimation, that is watering, photophobia and blepharospasm. This triad is also asked in exam. Lacrimation, photophobia and blepharospasm. Okay, and when you look at the picture, what do you see? You see that the eyes are large and the cornea is so hazy, it's giving almost a bluish appearance. So this kind, the cornea is large, the eyeballs are large, the eyeball is giving you almost a bluish kind of an appearance. This is typically the characteristic sign of congenital glaucoma. So this is what is called as your ophthalmus, large eyes which almost appear to be blue in size. So there is an increased pressure in the eye and there is an expansion of the globe. So this is congenital glaucoma. Okay, very commonly asked question. Again, another very simple but good question. In which condition do we have a decreased anterior chamber depth? Do we have it in open angle glaucoma, uveitis, retinitis pigmentosa, or are we going to have it in angle closure glaucoma? So what will we say? In which condition do we have a decreased anterior chamber depth? Do we have in OAG, uveitis, retinitis pigmentosa, or ACG? Chalo, who will tell me the answer? The answer is ACG, angle closure glaucoma. We have a decreased anterior chamber depth. We have a shallow anterior chamber in angle closure glaucoma. So in angle closure glaucoma, what is essentially happening is that the iris comes forward and it closes the angle. Now what is the angle? The angle is this wedge. So if this is the cornea and this is the iris, this is your angle. The angle is that wedge between the iris and the cornea. So if the iris comes forward and it narrows the angle, that causes angle closure glaucoma. So you have a shallow anterior chamber in case of angle closure glaucoma. And in open angle glaucoma, what are you likely to have? You will have a normal anterior chamber. Because here the problem is not that the angle is closing, the problem is that the trabecular meshwork is not functioning properly. So there may be thickening of the pores, thickening of the trabecular meshwork. So the pores of the trabecular meshwork don't function properly in OAG, but the anterior chamber depth is normal. So in anterior chamber depth, normal anterior chamber depth is seen in OAG, and shallow anterior chamber, this is seen in angle closure glaucoma. Okay, so angle closure glaucoma, you will have a shallow anterior chamber. Now look at this question. For laser iridotomy, which is the laser used? Argon laser, Nd:YAG laser, excimer laser, or CO2 laser? What is the laser used in laser iridotomy? So where do we do a peripheral laser iridotomy? In which kind of glaucoma? Peripheral laser iridotomy. This is the treatment of choice. This is the treatment for ACG, that is angle closure glaucoma. So we just learned that in ACG you have a shallow anterior chamber, and what is the treatment that you do? You do a peripheral laser peripheral iridotomy. You do a laser peripheral iridotomy, laser PI, laser peripheral iridotomy. So what is the laser used? Laser peripheral iridotomy. What is the laser used? Will you be able to tell me? Yes, the laser used is Nd:YAG laser. So laser peripheral iridotomy, the laser used is Nd:YAG laser. Now in laser PI, this Nd:YAG laser is used for laser PI. Just learn this up. This is used, Nd:YAG laser has two important applications. One is this, that is laser PI, and the other is laser capsulotomy, which is done for PCO. laser capsulotomy, which is done for PCO, and laser PI, which is done for angle closure glaucoma. Both these, they are done with ND-YAG laser. So two very important applications of ND-YAG laser. Please memorize this. So laser peripheral iridotomy or laser PI, which is done in angle closure glaucoma, and laser capsulotomy, which is done for PCO, that is posterior capsule opacification, which is also called as after cataract. There, the laser capsulotomy that you do, these two are important applications of ND-YAG laser. Now, one more thing I want you to learn. Tell me, where is excimer laser used? Will you be able to tell me? Where do we use excimer laser? This also can come. Where do we use excimer laser? Where do we do, what is a very, very important application of excimer laser in ophthalmology? Very, very important application of excimer laser. Okay, I'll tell you, memorize this. Very, very important application of excimer laser in ophthalmology is LASIK, which is a type of refractive surgery. Correct. So this is a type of refractive surgery. So LASIK, which is a type of refractive surgery, this is the very important application of excimer laser. So ND-YAG laser, this is used for laser PI in ACG, laser capsulotomy for PCO. Excimer laser, this is used for LASIK, which is a type of refractive surgery. Okay, sure. Let's go to the next question. Which of the following is not a characteristic of open angle glaucoma? So high intraocular pressure, increased cup disc ratio, visual field defect, and disc edema. Which of them is not seen in open angle glaucoma? Which of these is not seen in OAG? Which of the following is not a feature of open angle glaucoma? High intraocular pressure, increased cup disc ratio, visual field defect, or disc edema? Which of the following is not seen? So which one will you mark? Correct. The answer is D. Disc edema is not seen. So in open angle glaucoma, what are the features? You will have a normal AC depth, that is normal anterior chamber depth. You will have high intraocular pressure, obviously. High intraocular pressure. You will have a large cup. So in the optic disc, what do we see in the optic disc? You will see something like this. If this is your disc, you will have a large cup. So there is a depression at the center which is called as the cup, and so what happens is the size of the cup becomes large. So there is a large cup and increased cup disc ratio. So the ratio of the cup is to disc. So here the ratio of the cup is to disc is increased. And of course you will have visual field defects. These are visual field defects. These are the diagnostic criteria for OAG. So you should have a normal anterior chamber depth. The intraocular pressure should be raised, the cup should be large, and there should be an increased CD ratio. That is, cup is to disc ratio should be increased, and you should have visual field defect which is suggestive of glaucoma. But disc swelling or disc edema, this is not a feature of glaucoma. So these, please memorize, these are the characteristics or the diagnostic criteria for OAG. Okay, chalo. Let's go to the next question. Where do we do argon laser trabeculoplasty? Argon laser trabeculoplasty is done in which type of glaucoma? Angle closure glaucoma, angle recession glaucoma, secondary glaucoma, or open angle glaucoma? Where do we do this? Any idea? Where do we do argon laser trabeculoplasty? Okay, I'll tell you, it is done in OAG, open angle glaucoma. Open angle glaucoma. So what are the treatment options for open angle glaucoma? Open angle glaucoma, the first line of management is medical management. So please learn this. The first line of management for OAG is medical management, which means controlling of the IOP with eye drops. Now if that does not work, then what you will do? Then you will go for this trabeculoplasty. That is laser treatment of the trabecular meshwork, trabeculoplasty. And the last option is surgery. And what is the name of this surgery? The name of the surgery is trabeculectomy. Trabeculectomy. So these are the treatment options for OAG which you have to know. So what are the treatment options for OAG? The treatment options are, the first line of management is always medical management, which means controlling of the IOP with eye drops. Controlling of the IOP with eye drops. Okay, if that doesn't work, then the next line is trabeculoplasty. And if that also doesn't work, then we have to go for trabeculectomy, which is surgery. Which is trabeculectomy or surgery. Okay, shall we go on to the next question? Sorry, just give me 1 minute. Am I audible and visible? I hope I'm audible and visible. Am I audible and visible? Okay, thank you. So let's go to the next question. This is again a very commonly asked question. It's asked in different ways. Which of the following is not correct regarding the clinical condition shown in the image? This is more common in warm areas. This lesion is attached to the cornea. It causes myopia and iron deposition is found. Which of the following is not correct regarding the clinical condition that is shown in the picture? It occurs more commonly in warm areas. It is attached to the cornea. It causes myopia and iron deposition is found. So which one will you be? First of all, what is this? You can see this kind of a fleshy mass which is growing onto the surface of the cornea. So this is actually a conjunctival degeneration. It's not a normal conjunctiva. It's a degenerated conjunctiva which is growing onto the surface of the cornea. This is called as a pterygium. So basically they are asking us which of the following is not true about pterygium. Correct, it causes myopia. This is wrong. So it is attached to the surface of the cornea. That's correct. It is associated basically with UV ray exposure. So people who spend more time out in the sun, especially in warmer areas, the pterygium is more common. And close to the head of the pterygium, sometimes you can have iron deposition, and this happens in the form of a line. Do you know what is the name of the line? Iron deposition close to the head of the pterygium. It results in the form of a blackish line close to the head of the pterygium. What's the name of the line? Often asked as MCQ. What is the name of the line? It is called as Stocker's line. Again, important for MCQ. It's called as Stocker's line. So pigmented line close to the head of the pterygium. This is called as your Stocker's line. Right, so all these are correct. So what's wrong is it causes myopia. It does not cause myopia. So what does it cause? What does this cause? This pterygium grows onto the horizontal surface. It grows onto the horizontal axis. So it flattens the horizontal axis of the cornea. It flattens the horizontal axis of the cornea. It flattens the horizontal axis of the cornea, and therefore it ends up causing astigmatism. So it causes astigmatism. It causes astigmatism. It does not cause myopia. So this is, again, it has been asked in NEET PG also. It has been asked in FMG also. So very commonly asked question. So what is the pterygium? Please memorize this also. The pterygium, this is an elastotic degeneration of the conjunctiva. It's an elastotic degeneration of the conjunctiva, and here this wing-shaped fold of the conjunctiva grows onto the surface of the cornea. It is associated mainly with UV ray exposure, and close to the head of the pterygium you can have a pigmented line due to iron deposition, which is the Stocker's line. And what this pterygium does is it flattens the horizontal axis of the cornea, and it often results in astigmatism. It does not cause myopia, it causes astigmatism. Now let's come to what is the treatment of pterygium. So let's go to this. What is the treatment of pterygium? What is the treatment of choice for recurrent pterygium? So simple excision, observation, excision with conjunctival autograft, treatment with mitomycin C. What is the treatment of choice for recurrent pterygium? So what are we going to mark here? Which is the option that is most suitable? Which is the option that is most suitable? The answer is C, that is excision with conjunctival autograft. Excision with conjunctival autograft, which is also called as CAG, excision with conjunctival autograft. So see, the most important cause of recurrence of pterygium is simple excision. So when we do a simple excision, this results in recurrence. This is what results in recurrence. When we do a simple excision, this results in recurrence. And to prevent the recurrence, we can do a treatment with mitomycin C. We can also do a conjunctival autograft. But the one that is more commonly done or recommended is excision with conjunctival autograft. So CAG, this is the treatment of choice for recurrent pterygium. But if we are asked what are the methods to prevent recurrence, both can be answers. That is, treatment with mitomycin C can also be an answer, and conjunctival autograft can also be an answer. But the better one, the treatment of choice for a recurrent pterygium, is excision with conjunctival autograft. Okay, let's go to the next question. Again, a very important question. A lady presents with sudden painful loss of vision which worsens on eye movement. So there is a sudden loss of vision and it is associated with pain, but not pain on all times. Pain is associated with eye movements. There is RAPD. What is RAPD? The full form of RAPD is relative afferent pupillary defect. So relative afferent pupillary defect. And there is a central scotoma. A central scotoma means there is a central black area. The patient is not able to see at the center. So there is a sudden loss of vision. There is RAPD. What is RAPD? RAPD suggests that the site of the lesion is actually the optic nerve. RAPD suggests that the site of the lesion is the optic nerve. So here the answer is optic neuritis. So what is optic neuritis? Optic neuritis obviously means, it essentially means inflammation of the optic nerve. So what are the important points to remember? Number one is that there will be a sudden loss of vision, and this loss of vision is often associated with eye movements. If you check for the pupillary reactions, you will get RAPD, that is relative afferent pupillary defect. If you do a perimetry, you will get a central scotoma. Right? Now, I just want you to learn a few things about optic neuritis just to complete the topic. So, see, you can have 3 types of optic neuritis. Just to, I want you to learn this small part that there are 3 types of optic neuritis. You can have something called as retrobulbar neuritis. You can have retrobulbar neuritis. Retrobulbar neuritis means that the portion of the nerve, optic nerve, which is behind the globe, that is the part which is affected. So here, the portion of the nerve which is behind the globe is affected. Portion of the nerve which is behind the globe is affected. Then you have something which is called as papillitis. Papillitis means that the optic disc is affected. This is the part of the nerve that is inflamed. And the third one is called as neuroretinitis. Neuroretinitis means that the optic disc is affected and the surrounding retina. The optic disc is affected and the surrounding retina. Okay, these are the 3 types of optic neuritis. So retrobulbar neuritis means the portion of the nerve which is behind the globe is affected. Papillitis means the optic disc is affected, and neuroretinitis means that the disc and the surrounding retina is affected. Okay. Now remember this. In retrobulbar neuritis, the disc is normal. The disc looks normal in retrobulbar neuritis. In papillitis, the disc looks like this. It is a swollen and red colored disc. This is what the disc looks like in papillitis. You can get this as an image based question. So if you have this kind of a swollen and red colored disc, then that is papillitis. And if you have this kind of a swollen and red disc, and see you have these exudates here in the retina. See, you have this kind of a swollen disc and you have exudates in the retina. This is neuroretinitis. This is neuroretinitis. So you can, these are very, very typical images. So we can get them as image-based questions. So these are the three types of optic neuritis. Retrobulbar neuritis, you will have a normal looking optic disc. In papillitis, you will have this kind of a red and swollen optic disc. In neuroretinitis, you will have this kind of a swollen and red optic disc, and you will also have exudates in the surrounding retina. Okay, so these we can get as image-based questions. Okay, and what is the treatment for optic neuritis? Who will tell me? Again, important common question. What is the treatment for optic neuritis? Treatment for optic neuritis is? It's inflammation, right? So what will be the treatment? It is inflammation. So what is the treatment? What is the treatment for optic neuritis? Yes, it is steroids. So steroids, this is called as pulse steroid therapy. So pulse steroid therapy, that is IV methylprednisolone followed by oral steroids. That is called as pulse steroid therapy. That is the treatment for optic neuritis. Okay. So these are a few things. I think most of you answered the question correctly, but these are a few important points which I thought that you should know. Now let's come to another very important topic, that is infective keratitis. A patient presents with history of trauma with vegetative matter and there is pain, redness and photophobia. What is the likely cause? Herpes simplex keratitis, acanthamoeba keratitis, bacterial keratitis or fungal keratitis. So which one are you going to mark? And what is the telltale point in the question? HSV keratitis, acanthamoeba keratitis, bacterial keratitis or fungal keratitis. So which are you going to mark here? The telltale point in the question is this, that there is a history of trauma with vegetable matter. And there is pain, redness and photophobia, which is obviously suggestive of keratitis in here. Correct. So the answer here is fungal keratitis. So fungal corneal ulcer, because there is a history of trauma with vegetable matter. Or the question can also mention that it is a farmer and it is the harvest season. So that is the time when the farmers, they cut their crops and they get this, they are more likely to get this kind of trauma with vegetative matter. So if the question says that there is an ulcer with a preceding history of trauma with vegetative matter, or it says that it's a farmer who has presented with this kind of condition in the harvest season, all this points to a diagnosis of fungal keratitis. Okay, now what we'll do is we'll quickly revise what are the important points that we have to remember about bacterial corneal ulcer and about fungal corneal ulcer. So, in bacterial corneal ulcer, the symptoms tend to be more pronounced. The symptoms are more pronounced in case of a bacterial ulcer. Please remember these points. These are the telltale things that will be mentioned in the question. In case of fungal corneal ulcer, the symptoms are less pronounced. Symptoms are less pronounced. And as this question mentioned, there will be a history of trauma with vegetative matter. History of trauma with vegetative matter. In a bacterial corneal ulcer, it will be mentioned usually that it is a single ulcer and the margins of the ulcer, they will be well defined. So single ulcer with well defined margins. Single ulcer and well defined margins. This is for a bacterial ulcer. Whereas for a fungal ulcer, what do you have? You usually have one large ulcer and multiple small ulcers surrounding it. And what are these called? They are called as satellite lesions. Satellite lesions. And the margins of the ulcer, in case of a fungal corneal ulcer, it is mentioned that the margins are typically described as feathery or fuzzy. Feathery or fuzzy margins. And also the surface of the ulcer is described as dry and leathery. These are the important words that you must remember. One of these words will be there in the question which will guide you to the answer. So see, in bacterial ulcer, the symptoms are more pronounced. It is a single ulcer. The margins of the ulcer are well defined. For a fungal corneal ulcer, the symptoms tend to be less pronounced, but they will usually mention in the question that there is a history of trauma with vegetative matter. And it's usually not a single ulcer. There are multiple ulcers. There is one large ulcer and some smaller ulcers which are called as satellite lesions. The margins are typically described as fuzzy or feathery, and the surface of the ulcer is typically called as a dry and leathery surface. So some of this will be there in the question. And also you can get it in the form of an image. So suppose I give you get this as an image number 1 and image number 2. Now try looking at image number 2. Will you be able to tell me whether we should call this as bacterial or fungal? If we look at image number 2, will you be able to tell me whether we should call this as bacterial or fungal? From what we just learned, we can get this as image based question also. What should we say? Is this bacterial or is this fungal? Image number 2, should we say it's bacterial or fungal? Correct. This is a fungal ulcer because see, these are your satellite lesions. You can see one large ulcer and beside it there are smaller ulcers. So these are your satellite lesions. So that is why we are going to call this as a fungal corneal ulcer. Whereas in picture number 1, see, there is this single ulcer and the margins of the ulcer are also sharp. They are well defined. There is a single ulcer and the margins of the ulcer are also reasonably sharp. So this is more likely to be a bacterial corneal ulcer. This is more likely to be a bacterial corneal ulcer. So you can get this as an IBQ also. So if you get this kind of a large ulcer in the marg and you have like smaller ulcers surrounding it, that is satellite lesions, we will mark it as fungal. Otherwise, we are going to mark it as bacterial. Which is the drug that is contraindicated in fungal keratitis? Acha, before that, let us just quickly learn. For bacterial corneal ulcer, what do we give? What is the treatment? For bacterial corneal ulcer, you will give fortified antibiotic eye drops. Fortified antibiotic eye drops means antibiotic eye drops under high concentration. And along with this, you have to give atropine eye drops. Why? Because atropine eye drops are cycloplegic and they help to relieve the pain. So for bacterial corneal ulcer, the treatment is fortified antibiotic eye drops, which means antibiotic eye drops under high concentration, and atropine eye drops. For fungal corneal ulcer, obviously antifungal eye drops. And what is the commonly used antifungal? This also comes as MCQ. Antifungal eye drops. Which is the commonly used antifungal eye drops? It is natamycin. Antifungal eye drops, that is natamycin, and also along with that you have to give atropine eye drops because here also this helps in pain relief. It acts as a cycloplegic and helps in pain relief. So fortified antibiotic eye drops and atropine eye drops for bacterial corneal ulcer, antifungal eye drops usually natamycin, and atropine eye drops for fungal corneal ulcer. Right? So now we come to the next question, which is the drug that is contraindicated in fungal corneal ulcer. In fact, not just in fungal, both in bacterial and fungal corneal ulcers. Which is the drug that should never be given? So will you be able to tell me the answer to this? Which is the drug that we should never give in bacterial or fungal corneal ulcers? Which is the drug that is absolutely contraindicated in bacterial and fungal corneal ulcer? Correct, it is steroids. Because the steroids, they will suppress the local immunity and what they will do is they will worsen the ulcer. So steroids are never to be given in bacterial and fungal keratitis. So we must never give steroids for both bacterial and fungal corneal ulcers. Right? So let's go to the next question. So this much, I think all that we discussed here, please memorize all these points. These are very, very important. Some of these have already been asked, the others are likely to be asked. how to differentiate between fungal and bacterial ulcers, what is the treatment, how to look at the image. Now the next one. Which of the following is true about dendritic ulcer? Hypopion, decreased corneal sensation, increased corneal thickness, or desmetocele? Which of the following is true about a dendritic ulcer? Where do we typically get a dendritic ulcer? Dendritic ulcer is typically seen in HSV, that is herpes simplex virus keratitis. HSV keratitis, this causes dendritic ulcer. And what is the typical feature of dendritic ulcer? Hypopion, decreased corneal sensation, increased thickness, desmetocele. Which one will you choose? Very good. The answer is decreased corneal sensation, and that is why dendritic ulcer is typically described as a painless ulcer. It causes decrease in corneal sensations, and that is why HSV keratitis or dendritic ulcer is typically described as a painless ulcer. Right, now what is the treatment for dendritic ulcer? Will you be able to tell me? What is the treatment for dendritic ulcer? Will anybody be able to tell me what is the treatment for dendritic ulcer? What is the treatment for dendritic ulcer? Yeah, it is actually a very actively replicating virus which causes dendritic ulcer. So the treatment for dendritic ulcer, it is acyclovir eye ointment. Acyclovir 3% eye ointment. That is the treatment for dendritic ulcer. Acyclovir 3% eye ointment. Acyclovir eye ointment is the treatment for dendritic ulcer. Okay. Now let's go to the next one. Yeah, I wanted you to have a look at these two images also. This also is a very typical image. It has come many times in the exam. Once again here, in case of dendritic ulcers, the ulcers, they tend to be, in the early stages, they tend to be very small. And to make it easy to identify the ulcer, often the ulcer has to be stained with fluorescein dye. So here we are staining the ulcer with fluorescein dye, and you are putting on again the cobalt blue filter of the slit lamp. You are putting on the cobalt blue filter of the slit lamp. So you stain the ulcer with fluorescein dye, you put on the cobalt blue filter of the slit lamp, and when you do that, look at the first one here. What you see is, you see an ulcer like this, right? It is like you see a branching ulcer like this. This is typically what we call as dendritic ulcer. This is dendritic ulcer. So look at the ulcer here, look at this image. You will see that there is a branching ulcer, a linear ulcer, and there are branches. This is a dendritic ulcer. If you get this, you have to be able to identify that this is HSV keratitis. And dendritic ulcer, if it is not treated, it can progress and then it looks something like this. This is called as a geographic ulcer. This is large and it does not have that kind of a very typical shape as a dendritic ulcer. So this is a geographic ulcer. This is also HSV. Treatment is the same. Acyclovir 3% iron. Okay, so I hope you will be able to identify these images. The ulcer is stained with fluorescein dye. We are putting on the cobalt blue filter of the slit lamp. There is a linear ulcer with branches, that is dendritic, and in the later stage we have this kind of a large ulcer, that is your geographic ulcer. Okay, let's go to the next question. Which of the following is the risk factor for acanthamoeba keratitis? Acanthamoeba keratitis, extended wear contact lenses, hypertension, band-shaped keratopathy, hyperlipidemia. Which of the following is a risk factor for acanthamoeba keratitis? Which of the following is a risk factor for acanthamoeba keratitis? Tell me which one should be mark? Okay. Extended wear contact lenses, hypertension, band-shaped keratopathy, hyperlipidemia. Okay, the answer is extended wear contact lenses. That is the answer, extended wear contact lenses, because acanthamoeba keratitis, this is associated, this one of the main risk factors for the development of acanthamoeba keratitis is contact lens misuse. Not the use of contact lenses, it is actually the misuse of contact lenses. So misuse of contact lenses is one of the main risk factors for the development of acanthamoeba keratitis. And what does a typical acanthamoeba keratitis look like? It looks like this. This is typically called as a ring ulcer. So see, look at the lesion. It looks like a ring here, which is concentric to the limbus. This is a ring ulcer. Okay, so important risk factor for acanthamoeba keratitis is contact lens misuse. And what is the typical appearance of acanthamoeba keratitis? It looks like a ring. It's called as a ring ulcer. And the third important question, what is the drug of choice for acanthamoeba keratitis? The drug of choice for acanthamoeba keratitis, this is remembered as PHMB, that is polyhexamethylene biguanide. PHMB, that is polyhexamethylene biguanide. So please remember this. 3 things to memorize under acanthamoeba. Most important risk factor, contact lens misuse. What is the typical appearance of the ulcer? It is a ring ulcer. What is the drug of choice? PHMB, polyhexamethylene biguanide. Okay, so this is about your acanthamoeba keratitis. Chalo, let's go to the next question. Collagen cross-linking is used in which disease? Corneal ulcer, corneal dystrophies, keratoconus or uveitis. Collagen cross-linking is used in which disease? Corneal ulcers, corneal dystrophies, keratoconus or uveitis. Corneal ulcers, corneal dystrophies, keratoconus or uveitis. Tell me what's the answer. Okay, the answer is keratoconus, right? The answer is keratoconus. So keratoconus, what is this? This is a corneal ectasia. This is a corneal ectasia. What is this ectasia exactly? There is a localized protrusion of the cornea which is associated with thinning. So there is a localized protrusion of the cornea, and this protruded cornea is also thinned out. Localized protrusion of the cornea which is also associated with thinning. So this corneal collagen cross-linking, this is done with riboflavin. So corneal collagen cross-linking with riboflavin, how is it typically written as? It is written as C3R, or some people write it as CXR. C3R or CXR. This is, see here, the cornea is protruded, right, and it is thinned out. So this corneal collagen cross-linking is a process which helps to flatten the cornea to a certain extent. It helps to flatten the cornea to a certain extent. So this ectasia means localized protrusion of the cornea with thinning. It can be treated with C3R, corneal collagen cross-linking with riboflavin. I just want you to have a look at 2 images related to keratoconus. So this is keratoconus. See, this is the typical image of keratoconus where you can see that this cornea is protruded. The cornea is like this. There is a localized protrusion. And if you look at the thickness, you will find that this part which is protruded is also thinned out like this. So this is your keratoconus, protrusion of the cornea which is associated with thinning. You should be able to identify this image. And another common image-based question that comes from here is this. So when a person with an advanced keratoconus is asked to look down, so see, when the person is looking down, what is happening? This protruded cornea is pressing on the lower lid. Right? So now this sign, when the patient with an advanced keratoconus is asked to look down, this protruded cornea presses on the lower lid, and this sign has a name. Will anybody be able to tell me what is this? What is the name of this sign? Very common image. Very common and important question. What is the name of this sign? This sign is called as this is called as the Munson's sign. This is called as Munson's sign. So when a patient, this is a sign of an advanced keratoconus. This is usually seen in keratoconus which is very, very advanced. And here when the patient looks down, then this protruded cornea indents or presses the lower lid. This is called as your Munson's sign. Okay? These two things you have to remember about K-conus. The given instrument is used to assess. What do we use this instrument for? Do we use it to evaluate the corneal sensation, the corneal endothelium, the corneal thickness, or the corneal curvature? What do we use this for? Do we use it for corneal sensation, corneal endothelium, corneal thickness, or curvature of the cornea? What is the use of this instrument? Now this instrument, this is actually a Placido disc based corneal topographer. It's a Placido disc. So you see these round things. This is a Placido disc based. This is an instrument which helps to evaluate the surface and the curvature of the cornea. This is a corneal topography machine, and this is used to evaluate the curvature of the cornea. And what is its application? Its application is in diseases like keratoconus, where you want to evaluate the corneal curvature. So see, if you go to this picture, what is happening here? The curvature of the cornea is increased, right? The cornea is protruded. So the curvature of the cornea is increased, and you get a surface irregularity, and that is taken up or measured by this instrument. So this is used to evaluate the curvature of the cornea, and one of its important applications is keratoconus. Okay, let's go to the next question. Again, another very, very commonly asked question. Where do you get to see Art's line? Where do you get to see Art's line? Vernal keratoconjunctivitis, flictanular conjunctivitis, ophthalmia neonatorum, or trachoma? Where do we get to see Art's line? Vernal keratoconjunctivitis, flictanular conjunctivitis, ophthalmia neonatorum, or trachoma. Where do we get to see Art's line? Good. It is seen in trachoma. It is seen in trachoma. So, Art's-Line and Herbert-Spitz, both of them are seen in trachoma. Now, Herbert-Spitz is also seen in trachoma, and trachoma is caused by, Chlamydia trachomatis, right? It is caused by Chlamydia trachomatis. And what are the serotypes of Chlamydia trachomatis? It is A, B, BA, and C. A, B, BA, and C. Chlamydia trachomatis, serotypes A, B, B, and C, they cause trachoma. And in trachoma, you get to see this. You get to see Art's line and you get to see Herbert-Spitz. I want you to have a look at these two images because they can also come as IBQ. So you see this kind of a whitish line here in this picture here. This is a picture of the everted upper lid. So the upper lid has been everted and you get to see this white line of scarring. This is your Art's line. This is the Art's line. And you see these depressions close to the upper limbus. These are your Herbert-Spitz. These are the Herbert-Spitz. Both these can come as MCQs and they can come as image-based questions. So both these are seen in trachoma. They are seen in the scarring stage of trachoma. So when you evert the upper lid, you can see this kind of a whitish line of scarring, which is your Art's line. And close to the upper limbus, you can see these depressions, which are called as your Herbert-Spitz. They are seen in the scarring stage of trachoma. Right? Now, what is the strategy that is used for the treatment of trachoma? You remember what is the strategy? The name of the strategy is SAFE strategy. SAFE strategy, this is the strategy that is used for the treatment of trachoma. And what does SAFE stands for? S stands for surgery, A stands for antibiotics, F stands for facial hygiene, F stands for facial hygiene, and E stands for environmental modification. Environmental modification. S stands for surgery, A for antibiotic, F for facial hygiene, and E for environmental modification. So this is your SAFE strategy. This is the safe strategy that is used for the treatment of trachoma. This also again is very, very important, very commonly asked in exams. Okay. So we have done quite a few questions from conjunctiva and cornea. Now let's move on to another set, that is the retina. The questions from retina. Tell me, what is the size of the optic disc? Is it 0.5 mm, 1.5 mm, 2 mm or 2.5 mm? What is the size of the optic disc? So what will be marked here? What is the size of the optic disc? 0.5 mm, 1.5 mm, 2 mm, 2.5 mm. Okay, so there are a few values that we need to memorize from here. Yes, the answer is 1.5 mm. 1.5 mm. So I'll just show you the picture. This is the normal picture of the normal retina. This is your optic disc. So what is the diameter of the optic disc? The diameter of the optic disc is 1.5 mm, as we have been asked in the question. Now they can also ask us what is the diameter of the macula. So this part, which is the macula, that is the part between the two arcades. This part between the two arcades, this is the macula. The diameter of the macula, please remember, it is 5.5 mm. So the diameter of the optic disc is 1.5 mm. The diameter of the macula is 5.5 mm. Now the centermost point of the macula here, this point, this is called as your fovea. This is the fovea. And what do you have to remember about the fovea? The fovea, this is the most light sensitive area of the retina. All these are MCQs. This is the most light sensitive area of the retina. And also please remember that this fovea, it has the highest concentration of the cone cells. These are both MCQs. It has the highest concentration of the cone cells. Okay, and another question that is asked is, what is the distance between the fovea and the optic disc? So this distance between the fovea and the optic disc, what is this distance? Will any of you be able to tell me what is the distance between the fovea and the optic disc? Okay, I'll tell you the distance between the fovea and the optic disc. This is typically described as 2 disc diameters. This is typically described as 2 disc diameters, which means roughly around 3 mm. 2 disc diameters or 3 mm. So memorize these three values. Diameter of the optic disc is 1.5 mm. Diameter of the macula is 5.5 mm. The distance between the optic disc and the macula is roughly 2 disc diameters, which is around 3 mm. Now the fovea, this is the centermost point, which is the most light sensitive area of the retina, and it has the highest concentration of the cone cells. All these are MCQs. Okay? Chalo, let's go to the next question. A 67-year-old patient presents with sudden loss of vision, and on examination the vision is like visual acuity is hand movements. RAPD is given and this is your fundus image. What is the diagnosis? What is the diagnosis? A hypertensive elderly patient is presenting to us with this kind of a loss of vision. RAPD is seen and this is the fundus image. And what is the likely diagnosis? So what is this picture showing us? That is what we have to understand. So what is this picture showing us here? Is it CRVO, CRAO, BRVO, or is it cystoid macular edema? Okay, see, what can we see in this image? This is a very, very typical image. You see that the whole retina is pale. So you get to see a pale and edematous retina, right? The whole retina appears to be pale. But only this fovea is the central point, that is the fovea. This is bright. So only the fovea, it appears to be bright. So the retina, it is pale and edematous, and it is only the fovea which is bright. So what is this appearance called? This appearance, this is called as typically cherry red spot. What is it called? It is called as cherry red spot. So the entire appearance is pale and edematous retina, only the fovea appears to be bright. This is called as cherry red spot. And where do we get to see cherry red spot? Cherry red spot, this is seen in CRAO, that is central retinal artery obstruction. Central retinal artery obstruction. So usually the question will mention that there is an elderly patient and generally either hypertension or diabetes or any this kind of systemic condition will be mentioned. What is the typical presentation? There is a sudden loss of vision which is painless. And on examination, you will find that the visual acuity is actually very bad. It will be like counting fingers close to face or hand movements. And the image that is given to us will be this kind of an image. Well, the entire retina will be pale and edematous and there will be a central fovea which is bright, and this appearance is called as cherry red spot. So this is CRAO, central retinal artery occlusion or obstruction. Okay, now let's look at, this is CRAO. Now, another question from retina. How many years does it take for retinopathy to develop in type 1 diabetes? 1 to 5 years, 6 to 10 years, 11 to 15 years, or 16 to 20 years? How many years does it take for retinopathy to develop in type 1 diabetes? So this question has been asked in a different way actually. So the answer to this is around 6 to 10 years. This is your answer. Now often it is asked in a different way, the same question, that when do you start the screening for diabetic retinopathy? When do you start the screening for diabetic retinopathy? So if it is a patient who has a type 1 diabetes, then we are going to start the screening after 5 years of diagnosis of diabetes. So 5 years after the diagnosis of diabetes, we are going to start the screening for diabetic retinopathy. So if it is an uncontrolled diabetes, then there is a likelihood of diabetic retinopathy. But if it is a type 2 diabetes, then we are going to start the screening immediately on diagnosis of diabetes. When do we start the screening? We are going to start the screening immediately on diagnosis of diabetes. Okay, so that's why we say that screening for diabetic retinopathy, in type 1 diabetes, we will do it 5 years after diagnosis, and in type 2 diabetes, we are going to start the screening immediately after diagnosis of diabetes. So, retinopathy develops within about 6 to 10 years if the glucose is not under control, if the blood sugar is not under control. Okay, now let's look at the next question. Where do we get to see microaneurysms? Microaneurysms are seen in which disease? Retinal detachment, diabetic retinopathy, uveitis, or cataract? Microaneurysms are found in which disease? Are they seen in retinal detachment, diabetic retinopathy, uveitis, or cataract? Microaneurysms are found in which disease? Microaneurysms are found in which disease? Yes, they are found in diabetic retinopathy. So please remember, microaneurysms, they are the first detectable lesion. These are the first detectable lesion in diabetic retinopathy. This comes as MCQ. And in which layer of the retina they found? They are found in the inner nuclear layer of the retina. Both these are questions. The first detectable lesion of diabetic retinopathy, and they are seen in the inner nuclear layer of the retina. So microaneurysms, they are the first detectable lesions, the earliest lesions of diabetic retinopathy. So I just want you to have a look at these two images, and this will help you to remember what are the things that we find in diabetic retinopathy. So in diabetic retinopathy, the early stage, I think all of you know, this is called as non-proliferative diabetic retinopathy or NPDR. Non-proliferative diabetic retinopathy or NPDR. So in NPDR, what is the earliest sign? The earliest sign is microaneurysms, as we just saw. Now microaneurysms, when they rupture, they give rise to hemorrhages, which are called as intraretinal hemorrhages. So intraretinal hemorrhages. So look at this image here, the first one. See, you can see these patches of red here. These patches of red, they are your intraretinal hemorrhages. So microaneurysms, some of the microaneurysms will rupture and give rise to hemorrhages. Some of the microaneurysms will leak and you will have these exudates. So see these small yellow dots that you see, they are exudates. They are called as hard exudates. They are caused by leaking microaneurysms, hard exudates. And you will also get some areas of infarcts. So look at these large white dots here, large white dots. They are called as cotton wool spots. What are they called? Cotton wool spots. What are cotton wool spots? They are nothing but infarcts. So these are the important features that you need to remember in NPDR or non-proliferative diabetic retinopathy, which is the early stage of diabetic retinopathy. So see, what are the features? Microaneurysms, which is the earliest feature. Then some of the microaneurysms will rupture, which will give rise to intraretinal hemorrhages. So you see these patches of red. Some of the microaneurysms will leak and they will produce hard exudates. So these small yellow dots. And then you will also have some areas of infarcts, which are these larger yellow dots, and they are called as cotton wool spots. So please remember these four important features of NPDR, which is the early stage of diabetic retinopathy. Microaneurysms, intraretinal hemorrhages, hard exudates, and cotton wool spots. Now the advanced stage of diabetic retinopathy is this. This is called as PDR, that is proliferative diabetic retinopathy. Proliferative diabetic retinopathy, and here the main feature that you will see is, look at these irregular blood vessels here. Look at these irregular blood vessels here. These are new blood vessels. So in proliferative diabetic retinopathy, the classical feature is neovascularization of the retina. Neovascularization of the retina, meaning formation of new blood vessels on the retina. So neovascularization of the retina or formation of new blood vessels in the retina, this is the feature of PDR, that is proliferative diabetic retinopathy. So you'll remember this now: NPDR, microaneurysm, hemorrhage, hard exudate, cotton wool spots. PDR, neovascularization of the retina, which is the classical feature. Okay, now let's go to the next question. Identify this investigation. What is this? Is it a fundus fluorescein angiography? Is it OCT? Is it ultrasonography? Or is it perimetry? That is visual field. What is this? What is the name of this investigation? Correct. This is fundus fluorescein angiography. So in this, what we are trying to do is, we are studying the retinal blood vessels. So you are injecting fluorescein dye into the patient's vein, antecubital vein. You wait for the dye to reach the retina and then you capture photographs of the retina, and you can see the dye inside the retinal blood vessels. So see, the fluorescein dye is there inside the retinal blood vessels, and this is going to help you to study the retinal vasculature mainly. So this is fundus fluorescein angiography. This helps us to study the retinal vasculature. This is an important investigation for retina. Okay, let's go to the next question. A child presents with night blindness and delayed dark adaptation. Which investigation is to be done to confirm the diagnosis? So there is night blindness and delayed dark adaptation, and which investigation is done to confirm the diagnosis? So what is the option that we will choose? Dark adaptometry, ERG, EOG, or retinoscopy? Which is the investigation we have to choose here? Please let me know the answer. What is the answer? Correct. The answer is ERG or electroretinogram. Electroretinogram. So what is the diagnosis here? The complaint of the child is night blindness. So most probably this is a problem of the rod cells, right? Because the rod cells are responsible for night vision or dim light vision. So a dystrophy of the rod cells of the retina, this is retinitis pigmentosa. This is a type of retinal dystrophy. So this is an important retinal dystrophy. This is retinitis pigmentosa, and here the rod cells of the retina are defective. To confirm the diagnosis, the test that you do is called as ERG or electroretinogram, where you record the electrical activity from the retina. Now, in a normal ERG, you have two waves like this. There is a down wave which is called as the A wave, and this down wave, it arises from the photoreceptor cells. And there is an up wave like this which is called as the B wave, and this arises from the bipolar or the Muller cells. This arises from the bipolar or the Muller cells. So there is a down wave which is the which arises from the photoreceptor cells, and there is an up wave which arises from the bipolar or the Muller cells. So basically in a patient of retinitis pigmentosa, the problem is with the rod cells. It is a defect or a dystrophy of the rod cells of the retina, and therefore it is this A wave of the ERG which will be affected, and that is going to help us to confirm the diagnosis. Okay, so nyctalopia or night blindness, delayed dark adaptation in a child may be suggestive of retinitis pigmentosa, and if you want to confirm the diagnosis, you have to do an ERG. But now let's look at the next question, which is going to tell us what does the clinical picture or the fundus picture of retinitis pigmentosa look like. So which of the following is seen in retinitis pigmentosa? Do we get to see arteriolar attenuation? Do we get to see neovascularization, retinal artery thrombosis, or papilledema? Which of the following is seen in retinitis pigmentosa? Which of the following is seen in retinitis pigmentosa? Which one will you choose? Arteriolar attenuation, neovascularization, retinal artery thrombosis, or papilledema? Correct. The answer is arteriolar attenuation. So basically the triad of signs in retinitis pigmentosa is, number one is disc pallor, waxy disc pallor. So the disc is pale. I'll show you an image to understand this. Next is attenuation of the blood vessels, that is arteriolar attenuation, and clumps of retinal pigments, which are called as your bony corpuscles or the bony spicules. So waxy disc pallor, arteriolar attenuation, and bony corpuscles or bony spicules. This is the triad of signs in retinitis pigmentosa. I'll just show you an image. This is also an image that can come in the exam. So look at this image. So look at the disc here. You see that the disc is pale. You have a pale disc. Number two, look at the blood vessels. The blood vessels can hardly be seen. So you have attenuated blood vessels. Attenuation of the blood vessels. And you see these clumps of retinal pigments in the mid periphery. These are called as your bony corpuscles or the bony spicules. The bony corpuscles or the bony spicules. This is retinitis pigmentosa. This can come as an IBQ as well. This can come as a simply an image based question. Okay, so what are the things? Let us just summarize what are the important things we learned about retinitis pigmentosa. It is a dystrophy of the rod cells of the retina. The patient presents with complaint of nyctalopia, that is night blindness. What is the triad of signs? The triad of signs is a pale disc, attenuation of the arterioles, and clumps of retinal pigments. So these black patches which are called as the bony corpuscles or the bony spicules. You can get this as an IBQ also. What is the investigation of choice? The investigation of choice is ERG, that is electroretinogram. And in electroretinogram, which is the wave that is affected, the wave that is affected is the A wave which arises from the photoreceptor cells. So all these are MCQs. All of them have come and all of them can come again. Okay, chalo. Let's go to the next question. A 1.5-year-old child presents with the following clinical picture, and the USG-B scan shows an intraocular mass with calcification. What is the likely diagnosis? Is it a congenital cataract? Is it retinoblastoma? Is it Eales disease or toxoplasmosis? What are we going to mark here? Which is the option that we will choose? 1.5-year-old child is presenting with this picture. So what is this picture? Look at the eye here. You have what is a white pupillary reflex, correct? What are we having? We have a white pupillary reflex. And what is the other name for white pupillary reflex? It is called as leukocoria. So a 1.5-year-old child. So roughly the age is 18 months. A child 18 months old presents with white pupillary reflex or leukocoria, and USG is showing a mass with calcification. So all this point to the diagnosis of retinoblastoma. Now this is again very, very important. So in this question, always these few things will be mentioned, that the age of the child will be between 1.5 to 2 years, because that's the commonest age of presentation. What is the commonest presenting feature? The commonest presenting feature is white pupillary reflex or leukocoria. And if you do an ultrasonography, you are likely to see a mass which is associated with calcification. So all this together gives us a diagnosis of retinoblastoma. And what is the treatment for a large intraocular retinoblastoma? That is a large and intraocular retinoblastoma, meaning which is confined to the globe, which is not spread outside. For a large intraocular retinoblastoma, the treatment of choice is enucleation. So please memorize this. What do we mean by enucleation? Enucleation means you remove the globe, removal of the globe with a portion of the optic nerve. Removal of the globe with a portion of the optic nerve. So for a large intraocular retinoblastoma, what do I mean when I say intraocular? I mean that the tumor is still confined to the globe, it has not spread outside. So for a large intraocular retinoblastoma, the treatment is enucleation, which means removal of the globe with a portion of the optic nerve. Okay, now identify this image. What is this? Is it a retinoblastoma, choroidal melanoma, nevus or HSV keratitis? Now what is this basically? Once you do an enucleation for retinoblastoma, the answer to this is also retinoblastoma. Once you do an enucleation, you send that specimen for histopath. And when you send the specimen for histopath, you will get to see this kind of a picture where there are these tumor cells arranged like this. This is called as a rosette pattern. And the most specific rosette for retinoblastoma, please remember, that is called as the FW rosette or Flexner-Winter-Steiner rosette. What is it called? It is called as the FW rosette or the Flexner-Winter-Steiner rosette. So when you have a large intraocular retinoblastoma, it has to be enucleated, and when you do a histopath, this is what you're likely to see. So you see these tumor cells around this central lumen, this rosette pattern, and the most specific type of rosette that you have here, this is called as the FW rosette or the Flexner-Winter-Steiner rosette. Okay, so these are the important questions from retina. Okay, so I think we will stop today's session here, and tomorrow we will join again at the same time. That's like 5 o'clock, and tomorrow I will be discussing a few other PYQs, previous year's questions, and also I will be discussing some one-liners, which I feel that as FMG students, some important one-liners which I want you all to know. So thank you very much for joining this session. You have been a very active and enthusiastic audience, and the rest of the PYQs in tomorrow's session, I will be discussing a few more PYQs, and also I will be discussing, as I said, I will be discussing the one-liners, important one-liners. So thank you very much everyone. See you again tomorrow at 5 p.m. Bye-bye.